Good afternoon, good evening, or indeed good morning, depending on where in the world you're joining us from. Hope everybody is keeping safe and well. And welcome to the fourth session of the Rehabilitation in Conflict webinar series, this time on traumatic brain injury. And I'm delighted that this session is being run by the International Society for Physical and Rehabilitation Medicine, ISPRM. Without further ado, I'm going to hand over to Dr. Maria Paul from ISPRM, who will take us through the rest of the session. Dr. Paul, thank you very much.
Thank you, Pete. Hello, everyone, and greetings from Adelaide, Australia, where the time is 1:30 in the morning. And I'm Dr. Maria Paul. I'm a rehab physician based here in Adelaide, but I'm also secretary for ISPRM, the ISPRM. And I'll be moderating the session today. And joining me in the Q&A will be Dr. Farooq Rathore, who's a professor in rehabilitation medicine. He's an army doctor in Pakistan. I also have Dr. Volodymyr Golik, who is from Ukraine, and he is the technical officer, disability and rehabilitation, WHO. But our main speaker, I will introduce, is Dr. Anas Hassan. He is a consultant in neurorehabilitation in UK since 2026, and his work spans inpatient, community, home-based and remote rehabilitation with a strong focus on service development, multidisciplinary working, and making efficient use of available resources to improve patient outcomes in challenging settings. Now, Dr. Hassan is originally from Gaza, Palestine. Dr. Hassan is a refugee whose journey across multiple countries has given him multinational experience and a deep understanding of different healthcare systems, cultures, and approaches to rehabilitation. He is committed to improving rehabilitation and disability care for Palestinians through education, guidance, and practical service development. He has led and supported on-the-ground physiotherapy teams to strengthen primary assessment and follow-up of amputee patients and has presented internationally, including on the Gaza Amputee Rehabilitation Initiative. He also completed a one-year Healthcare Leadership Academy program where he developed skills in team leadership and resource management in difficult circumstances, including war and natural disasters. So over to you, Dr. Hassan, and we'll have plenty of time for question and answers and discussions at the end. You may start putting your questions in the Q&A box straight away, and I'll be monitoring it.
Thank you, Prof. Maria. Hello, everyone. I'll just start by sharing the screen, and then we can take it from that. So, yeah. Okay, so I will just load this up now.
Yes, we can see the first slide on slideshow mode.
Fantastic. Okay. So good morning, good evening, or good afternoon, and welcome everyone. I'm Dr. Anas Hassan. I'm a consultant in neuro rehab medicine at Walkergate Park Hospital, which is in Newcastle, United Kingdom. And I'm presenting today on behalf of the Emergency Rehabilitation Committee of the International Society of Physical and Rehabilitation Medicine, ISPRM ERC, as part of this fantastic WHO-supported webinar series. So the title of my talk will be about traumatic brain injury, how in emergency management and rehabilitation implications. Over the next around 20 minutes, I will take you through the clinical landscape of the TBI, from the definition to the epidemiology, through the acute management and either rehabilitation, all the way to community-based strategies and long-term follow-up. This talk is designed to be relevant and particularly applicable, particularly in the low resources or resources limited, and conflict-affected settings. So before going into the content, let me just briefly walk through the structure of the session. We will cover 6 main areas. There will be an introduction to the condition, with what TBI is, how common it is, and who it affects. Secondly, will be adapted clinical management in emergency settings. The third point will be about the common acute complication you're likely to encounter. Then we'll discuss about rehabilitation challenges, both clinical and non-clinical. The fifth one will be how to adapt, or more about the adapted rehabilitation practice, including community-based strategies. And finally, will be about more mental health and psychological support for the TBI survivors. This is a broad topic, so I will aim to be concise and evidence-informed, focusing on what is most actionable in the field. So this slide will talk about the definition. So what exactly is traumatic brain injury? So traumatic brain injury is the definition I use from the Scottish Intercollegiate Guidelines Network, and is defined as traumatically induced structural injury and or physiological disruption of a brain function resulting from the external force, indicated by new onset or worsening of at least one clinical sign following the event. These signs include any period of loss or decreased level of consciousness, any loss of memory or event immediately before or after the injury, what we call amnesia, alteration, which is basically its change in the mental states, such as confusion or disorientation. Neurological deficits also happens, which includes weakness, vision change, aphasia, or sensory loss, or presence of any intracranial lesions on imaging. So what this definition captures is the breadth of TBI presentation, from small or subtle cognitive changes to the coma and structural hemorrhage. And the next slide we'll talk about more about the TBI, the prevalence and the epidemiology, but we will talk in the general context. So how prevalent is TBI? Mild TBI, which is basically a concussion, is account for around 100 to 300 per 100,000 per year, while moderate will be slightly less than that, 15 to 20 per 100,000. And then we'll go to the severe, which is around 12 to 14 per 100,000. Now, looking at the risk of death, it's basically rises sharply in severe cases and in elderly patients. Two important contextual factors are worth highlighting here. One is the TBI has a strong association with socioeconomic deprivation. Those in lower income setting have both higher exposure to injury and less access to care. Secondly, there's a significant lack of awareness and advocacy for the TBI within the wider first responder and emergency community. These are not just statistics, they are a call to action for all in the field. Now, this slide will discuss about the severity of the brain injuries and the classification system being used. There are 3 recognized categories that we are discussing about: mild, moderate, and severe. Now, mild TBI is characterized by loss of consciousness of less than 30 minutes, where Glasgow Coma Scale being used around 13 to 15, scoring 13 to 15, with a post-traumatic amnesia that will be lasting less than 24 hours. Less than 24 hours. And then if we look at the moderate TBI, there will be a shift that's in the state of unconsciousness, which is lasting 30 minutes to 24 hours, with a GCS of 9 to 12, and the PTA, the post-traumatic amnesia, will be 1 to 7 days, less than a week. The severe one, the severe TBI, is the loss of consciousness will be more than 24 hours, with a GCS 3 to 8, and the PTA exceeding 7 days. This is really important to know because this remains the most practical and widely available assessment tool in the field, which is why it anchors this classifications. Even in resources limited environments or austere environments, where imaging may not be available. So you can still classify. Now, we'll talk about this. I think maybe we've seen this slides a couple of times in this fantastic series of education sessions. So mechanism of blast injuries. Given the conflict-affected context many of us work in, understanding blast injuries mechanism is essential. There are 4 primary categories. There's a primary blast injury, results from the overpressure. And then the shock wave, this is the initial pressure wave that passes through the body and particularly damaging the 2 gas-filled organs like the lung and ears. Secondary injuries caused by projectile and debris propelled by the expulsion. The tertiary will be resulted from the body being physically displaced or thrown away. The quaternary will be affect everything else, burns, inhalation, or toxic substances. And sometimes there are 4 and 5, that's basically they are combined together because everything else can happen. In practice, most blast casualties or injuries will have a combination of these injuries types. So you will find it's not like one type of injury. And the more severity, that the more closer to the area of the blast itself. So the next slide is this infographic in this slide captures one of the most important realities in the TBI care globally. So it's a contrast or the comparison possible for in high income settings versus austere or conflict environments. In the high income care, they have specialized neuro ICU with continuous intracranial pressure monitoring and MRI availability. Also, there are intensive MDT, multidisciplinary teams using virtual reality, robotics, functional electrical stimulations, all of these, and the structured discharge to modified homes, areas that they can integrate well, and the community outpatient support. These are the availability in that high income care. Now, in austere, or I would say in conflict settings, the reality is very, very different. Overwhelmed fields and hospitals relying on basic GCS and clinical observation. So these are the main 2 elements. And also we rely on the family-led therapy using household items with perhaps 1 shared physiotherapist. Discharge to a refugee camp or a settlement camp or unmodified homes relying on community volunteers. These are these differences is not presented to discourage or put you down. It's there to motivate adapted practical approaches, which is the focus of this talk. Now, in this slide is talking about the main goals of the treatment. Regardless of the resources availability, the overreaching goals of the TBI remain constant. First, triage should be incorporate TBI condition with commitments to early rehabilitation involvement, not just acute life-saving measures. The second part is emergency life-saving measures must be prioritized, just acute life-saving measures. And these are the acute life-saving, mainly like airway, maintaining circulation, and preventing secondary brain injuries. The third point is improving functional outcomes, helping patients return to the meaningful life activities. Fourth is minimizing complications, long-term complications with proactive clinical management. And the fifth will be educating patients and their families or the caregivers. The family becomes the primary rehabilitation team, which is really important. These goals must be held all together at one package. So even with the clinical environment is constrained. Now, the few points we'll discuss about the adapted clinical management. So the foundation of the TBI management is in any setting is a neuroprotection. So neuroprotection is the prime. Preventing secondary brain injury on top of the primary insults. The first 4 strategies are 1, cerebral perfusion, meaning blood pressure management. We must avoid hypotension. The mean arterial pressure sufficient to maintain cerebral perfusion. That's what does it mean. The second thing is the oxygenation, maintaining oxygen saturation above 94% whenever possible. Then ventilation, avoiding hypo or hyperventilation, as both worsen outcomes. The fourth point is seizure prevention. Early prophylaxis should be considered, particularly in moderate to severe TBI. And these pillars are in most settings, they are the same, regardless of wherever it is it high income or low income, or like it's developed or non-developed. Now, the rest of the second four points, there will be 1 point for the temperature control, and we try to avoid any fever. And the following point will be glucose control. Try to avoid any hyper or hypoglycemia, raise or low, because they can cause more further injury to the brain. Pain control, still pain is really drives sympathetic activation to increase intracranial pressure. So trying to manage pain. And then we manage sodium level control and try to avoid particularly the hyponatremia. Collectively, all of these 8 strategies represent what we should be doing for every TBI patient, regardless of setting. Now we'll talk quickly about the operative and non-operative. So this slide is addressed the surgical dimensions of the TBI management. And again, the gap between the ideal and austere settings. The ideal surgical management, the prerequisites are CT imaging, a sterile operating theater, and an experienced neurosurgeon. The key indication for immediate craniotomy includes expanding hematoma, the skull fractures greater than 1 centimeter, and these points usually that you will need for some imaging. In a non-operative settings, or like I would say, in austere settings, you will use the non-operative methods, which will be a little bit of prioritizing shift with basic nurse to patient ratio and continuous clinical Glasgow Coma Scale monitoring. The emphasis is on medical neuroprotection, like head elevation to 30 degrees, blood pressure control, oxygenation, and seizure prophylaxis. The message is really clear here. When surgical options are not available, every component of the medical neuroprotection bundles becomes even more critical. Now, common acute complications can come like relevant to across all settings. The most important acute complications like cerebral edema, an elevated intracranial pressure, which is really the most critical, requiring close GCS monitoring and neurological assessment. Aspiration and dysphagia, which is managing through positioning, keeping the patient nil by mouth initially, and introducing oral intake slowly once the swallow been assessed. Paroxysmal sympathetic hyperactivity, PSH, is presenting as agitation, fever, and tachycardia. It's more of like sympathetic hyperactivity. Everything is firing up everywhere. This can improve with reduced stimulation and time, but needs recognition and avoid inappropriate overtreatment. Infections, UTI, pneumonia, and wound infections are common. So aggressive prevention, like hygiene, mobilization, and adequate hydration are still important. So early identification for each of these significantly reduce morbidity. Early rehabilitation, and we'll talk about some evidence and timing. This is an important slide, basically. And within days, so the earlier initiation of rehabilitation within days of medical stabilization. This is the evidence consistently shows us. It does correlate with significant greater function improvement. Every time with that you start early, you will get a better outcome. Even in the ICU phase, once the patient is hemodynamically stable, passive range of motion, exercises, and careful positioning should begin prevent contractions. As consciousness improves and command following is established, which has been guided by the GCS, we progress to active assisted exercises. In low resources setting, this means starting family supervised exercises. And here is the importance of having a family, as they will become the continuity of the rehabilitation. And family members, basic rehabilitation techniques to be taught for, you teach them. The message here is that rehabilitation is not something that begins after discharge or that begins only in later on once the patient stabilizes. It can start in the acute phase. Now, we'll talk about the post-traumatic amnesia, and which is a temporary expected stage of brain healing following TBI. and it is not permanent. Families must be reassured about that. And some people will say it's about like switching on and off of the brain, restarting the brain. Some family, they will accept that term. So PTA manifests as a profound confusion and disorientation to time and place, with inability to form or retain day-to-day memories, agitation, restlessness, and behavior that seems out of character. They will be literally like a different person to them. This behavior is driven by the injury, and that needs to be clarified to them. It's not like the patient's deliberate choice. Formal and how we need to make sure about the formal hourly testing using like tools, but the available tool like Westmed PTA scale is often impractical in resources limited setting, but still you can use that, the Westmed. Even in such contexts, clinical observation and orientation and continuous memory function should guide care. Like a practical question will be asking daily, does the patient know where they are? Do they remember yesterday? That simple question tells you a great deal. Now, for the practical family management, and you think about once the PTA is identified, the emphasis shifts to empowering family members as the frontline management team. 4 principles. The first one will educate caregiver, reassure the family that the patient's confused or aggressive behavior is caused by the brain injury, not their own choice or like that, not their deliberate action. This reduces guilt and fear in a big context. Secondly, de-escalate and simplify. Basically, do not argue or attempt to force memory to recall. We're trying to pushing inside that memories and making sure that the family or loved one that they are able to remember everything. Use gentle redirection. Short, simple sentences, one instruction at a time, and that's it. The third point will be environmental control. Environment is really crucial because you need to create a calm, predictable environment. Try to limit visitors, try to reduce noise, and keep familiar faces nearby. Because routine reduces agitation. The fourth point will be ensure safety. Prevent falls and wandering using floor mats, closed supervision, and avoid physical restraints, which worsen agitations. These are low-cost, high-impact interventions that any family member can implement with minimal training, but this needs guided by care professionals. Now, let's talk about the medication. Now, pharmacological management in the TBI requires cautious approach. For headache, prevention through activity pacing and avoiding cognitive fatigue is preferable to alongside reliance, okay, to analgesic reliance. And then you can't rely on it all the way. For agitation and aggression, environment modification should always be the first line strategy before reaching for medications. When medications are needed, the guiding principle is start low and go slow, due to the injured brain has increased sensitivity to the side effects. Specific options at low dose include gabapentin, 100 milligrams 3 times daily, valproate, which is one of medication used for mood dysregulation. Sorry for that. And then we have the olanzapine as a typical antipsychotics for severe TBIs. All dosing should be reviewed regularly, and medication should be tapered once the acute phase resolves. This is not a long-term medication. Now, for the acute and chronic rehabilitation, as we move on from that transition to subacute or like chronic rehabilitation phases, the principal shift toward functional goal setting using locally available resources, mats, household items, community spaces for ambulation training, rather than pursuing complex motor skills with sophisticated equipment's goals. Goals should be focused on everyday activity independence, like feeding, toileting, transfers, and basic mobility. These are the activities that determine quality of life and caregiver burden. Cognitive rehabilitation, in fact, it's basically you're looking at targeting attention and memory. should be delivered using low-cost methods like structured conversation, real-world tasks, and environmental cues. Neuroplasticity is activity dependent. The brain does not distinguish between a treadmill and a pathway through the market. Like, this is basically the same to the brain. What matters is the repetition and engagement and functional relevance to the task. This activity independent measures does show a practical observer-based tool. It's assessing 12 core activities across core, lower limbs, and upper limb domain. Activities including rolling over, sitting up, standing, walking, stair climbing, and fine motor tasks. Each activity is scored from 0 to 5 based on the level of assessment required. This tool is particularly valuable in conflict and low resource settings because it does not require specialized equipment, just trained observation. It provides a structured framework for tracking functional progress, able to identify which areas to focus on, and improve the communication between healthcare workers and community volunteers. And they try to help them also for the goal setting as well. Now we talk about the adaptive strategies. The next two slides will be around the adaptive strategies and the community-based at the moment. So in the absence of formal rehabilitation centers, community-based rehabilitation becomes the primary model. Level 1 adaptation means replacing high-tech interventions with outdoors walking, community ambulation, manual resistance training. The model supports early discharge home, typically within 2 to 4 weeks, or like basically replicating their home, or be able to be functional independently in their homes. And with a family-led therapy and periodic professional review, the empowerment approach is central. Train family members as a primary caregivers and provide written instructions with clear illustration. Local resources are used creatively. This is what I found also, like in my work before, like community spaces like schools, markets for gait training, community volunteers as peer supporter. The model is low cost, culturally appropriate, and evidence suggested improves family acceptance and long-term adherence to rehabilitation program. It's basically looking at sustainability when you are designing such service. The neurobiological principles underlining the low-cost therapy is powerful. High repetition of functional tasks drives the neuroplasticity regardless of the setting. Walking, stair climbing, and feeding tasks all recruit the same cortical circuits as gym-based or technology-assisted therapy when performed with sufficient repetition and engagement. Resources required include nothing more than just household items. For example, like a sand-filled bottle or like a stone-filled small bottles for resisting training. Community stairs and paths, short daily sessions of 20 to 30 minutes at home, more achievable and can be arguably more effective than 2 to 3 hours in a center-based session that may occur only twice per week. The aim is to start early with these kind of sessions because the outcome from community-based task-specific therapy are effective for recovery at minimal cost, and family involvement throughout builds the social sustainability of the rehabilitation program. Now, we talk about some complications, how to manage. In the low resources, that we need to be really vigilant and being proactive for in complication management. Pressure injuries, like prevent through aggressive positioning. We need to prevent it by aggressive positioning, early mobilization, and community-based skin monitoring. We need just let the family aware about that. For contracture and spasticities, we need daily passive range of motion and exercises with sustained stretching for 10 to 20 minutes. Try to do that, and serial splinting, using locally available materials if available. For infection, strict hygiene and adequate hydration. And also early recognition of the signs of a change in the mental status. There are some concerns about the post-traumatic hydrocephalus, which is basically when we in conflict areas, sometimes we don't have monitors, we don't have imaging. So basically we look at how to maintain close monitoring, because that will require neurosurgeon if available. Once been there, is need to be monitored. Couple of injuries like eye and ears injuries, because blast injuries frequently causes ocular and auditory damage that can be missed during triage when attention is focused on the life-threatening condition. Eye are common but easily overlooked. They can lead to permanent vision loss if not identified and treated promptly. In any blast injury, a systematic eye examination is really necessary. For ear injuries, the most common is tympanic membrane rupture, resulting in hearing loss, tinnitus, dizziness, and sometimes bleeding. These injuries, if you can see that, affect their rehabilitation potential, because any patient with unrecognized hearing loss will be perceived as non-compliant or confused. A patient with vision impairment will struggle with any written or rehabilitation materials. Now, last couple of slides is nutrition and management in war casualties. And we'll talk about nutrition, which is really a sensitive topic because it's a critical and often underappreciated component of the TBI rehabilitation. In war casualties, nutritional deficiencies are common and worsen outcome. So early oral intake should be initiated as soon as swallowing safety is confirmed. Even in austere settings, modified diet textures should be used for patients with dysphagia. Enteral feeding like nasogastric tube should be considered if oral intake is unsafe. Malnutrition must be actively addressed. It impairs wound healing. It's causing problems with the wound healing, immune function problems, neurological recovery. Micronutrient supplementation like zinc, B vitamins, vitamin C, and these helps and support recovery. Food safety is also relevant, especially in the camp settings where foodborne infections adds a burden of illness. It's basically a simple rule that the brain cannot repair itself without adequate fuel. Communications difficulties. Basically, the TBI commonly impairs communication. There are two points about it: receptive and expressive. That's how they can perceive the information when you talk to them. These are really profound implications to rehabilitation, psychosocial well-being. There are six domains about it. The aphasia, which is difficulty with language expression or comprehension. Cognitive and language deficit, affecting processing speed and word retrieval. Dysarthria is a slurred or unclear speech due to motor impairment. Auditory processing difficulties, particularly in blast injuries. Memory impairment affecting retention of therapy, instructions, and conversation, and social communication challenges impacting relationships. In practice, speech and language therapy should be integrated as early as possible. If they are not available, training to the family and the community about the cues and how to communicate, what are the methods of communication is really important. Now, if we looked at this slide is about the apologies for that. For follow-up, oops, okay, just something lagged from my side. Okay, so because these injuries are not self-limiting events, they are carrying long-term consequences that requires structured follow-up. Monitoring should be covering wound healing and any surgical sites, fracture healing, orthopedic complications, for chronic pain management, including post-traumatic headache and neuropathic pain, hearing and vision, as both can deteriorate or improve over time with appropriate input. And psychological health. The PTSD, depression, and anxiety are highly prevalent in the population, and if untreated, significantly impair rehabilitation gains. Long-term follow-ups does not require expensive infrastructures. It requires a structured review framework, trained community health workers, and a clear referral pathway when complications arise. Continuity of care across the acute to community, that is where outcomes are truly determined. Now, this will be my summary slide, and we'll talk about basically what are the key messages here. So as we said, explosions produce 4 overlapping injuries, the primary, secondary, tertiary, and quaternary, and there will be the 5th one. And patients must be systematically assessed for all of them. We need to be vigilant for delayed or hidden trauma, including TBI, intracranial hemorrhage, and sensory injuries. With being vigilant, that saves life. Rehabilitation is not a luxury. It's a core component of trauma management and should begin in the acute phase, adapted wherever its resources are available. And finally, we must address both the physical and psychological consequences of TBI. The injury does not stop at the skull. It affects the whole person, their family, and their community. And that would be my final slide. And thank you very much for your time and attention. I hope this talk has particularly been useful, whether you're working in with resources or wherever in limited supplies, because the core principle of the TBI management: protect the brain, start rehabilitation early, involve the family, empower the family, and watch for complications. It's the same everywhere and it's universally. Thank you once again for the ISPRM, ERC, and the WHO Eastern Mediterranean region, and World Physiotherapy, all our partner organizations, for making this webinar possible. And thank you very much.
Thank you very much, Dr. Anas. I do have questions. So I'll start off with the first question, which is about follow-up care. So the question is coming from Rahma Muhammad. It says, how can long-term rehabilitation be achieved in conflict context, especially post-discharge, and issues with compliance and consistent follow-up, which could be affected by the difficult context? Anas, are you happy to take that one?
Oh, yeah. I will share my experience, and I'm really happy for everyone, and also Dr. Vladimir, Farouk, and you, Maria. So I would say what my experience is basically, if you started from the beginning and you explained to the family what they needed, and you have a structured follow-ups, as I think the last few slides that mentioned about it, will help the family to understand what happened. So it's basically when you explain to them, this is the way how we follow up, this is what you anticipate, this is what you're focusing on, and this is how you treat, and then this kind of follow-up, and we will arrange, if we have a physiotherapist, to come to their place, or there will be someone aware about it. So on the long term, during conflict, you can't ask the patient to come back and forth, because that's also a burden to them. But when you teach their caregivers or the family, and you tell them what to do, because these injuries will recover if you are following the repetition, you're following the therapy, and you make sure that everything medically is stable. So areas that affected or difficult, in the difficult context, there is no right and wrong. It's always what you can adapt, how to be flexible, how to explain to the family what they should do. Okay, because the family, they anticipate that their loved one, they will need extra stuff. Basically, from the extra stuff like extra physiotherapy, and sometimes extra physiotherapists for a significant brain injury will be overwhelming and tiring for them. So you will take it slowly in the beginning, and then you can increase if the loved ones are getting better. So you can explain this early, and you'll find that they are accepting it. So
thank you for that. The next question is, thank you for your presentation. This is from Verena Kleiliger. My question is on the timing of starting early rehabilitation. I wonder, yes, Farouk, whether you want to answer this?
Okay, so again, as just, first of all, thank you very much, Anas, for your excellent presentation. I mean, it clarified many concepts. It was clear, it was slow, and it was easy to understand. Now, coming to this timing of rehabilitation, now the general principle applies everywhere. The earlier, the better. That's the first principle that we should try to apply everywhere, whether in wars, conflicts, or usual peace times. But the main challenge, as Anas has rightly pointed out, is that during conflicts, wars, and these kind of disaster situations, honestly, you don't have your ideal situation where you can offer these rehabilitation services. And based on my own personal experience of providing rehabilitation service, disaster affectees in October 2005 earthquake, and then later on in floods as well, I can tell you that in the real world out there during disasters, traumatic brain injury somehow gets neglected. So my recommendation would be as soon as you identify a case with a suspected or a confirmed traumatic brain injury. So what I was saying that, during disasters, usually you will not get the best of circumstances and the best of support that is usually required for a patient having a suspected or confirmed traumatic brain injury. In that case, I would recommend that whatever resources you have at your disposal, whether they relate to early diagnosis, early intervention, early mobilization, or maybe even early assessment that is going to help you create a long-term plan. Whatever you have at your disposal, please do utilize them. But if you are working in a good center and if you have a lot of things to offer to the patient, again, the principle remains there for traumatic brain injury, for spinal cord injury, for amputation. That is, earlier the rehabilitation, better would be the outcomes. Thank you.
Thank you. So the next question from Dr. P. Harish Yadav is, what is your take on vestibular pathologies in TBI patients? Should we do vestibular rehabilitation in all patients with TBI? I can take this question. So yes, vestibular dysfunction is a common complication of traumatic brain injury, and patients might experience dizziness, vomiting, nausea, all of those symptoms, which can be quite disabling. But not all patients will have vestibular dysfunction. So physiotherapists are very good at doing the assessment to see which patients have the benign positional paroxysmal vertigo or other vestibular issues. And then the ones who are positive, only they will need the treatment. And the treatment can be very effective, and it can just resolve the situation quite effectively. So that's my response to that question. The next one is from an anonymous attendee. Medical management for the raised intracranial pressure, and does physiotherapy have a role for raised intracranial pressure? If yes, what is our role as a physiotherapist? Anybody else? Farooq, Volodymyr, do you want to take that question?
I'm happy to tell my experience for that. Is that okay? So first, I will just share, and then I will ask also Dr. Volodymyr if they have any feedback about it. So in the field, if there is raised ICP, you need first to know what are the signs of the ICP. Okay, so the family, they need to be aware if there is any change in the cognition status, if they start becoming more confused, become having any seizures, if they become more vomiting or any kind of increased intracranial pressure. That's the same for the physiotherapist, the same for the doctors, the same for anyone. This is the first thing. Now, how to manage it, ICP, is basically by prevention from aggravating factors. So how the ICP happened, was it delayed management for something in the brain injury? Was something hidden we don't know about it? Was the patients being not managed initially promptly and then they have more ICP? Sometimes things being there like pathological or structural in the brain that causing the ICP, other than the medical. So raised ICP, usually you can prove it with some clinical sign. If you have these signs, you need medical, maybe you will need medical intervention. So the raised ICP by itself as a term comes under, it comes with different causes. So if you identify the cause, you can treat ICP. This is how we've been looking at. The most common one I found that for increased ICP, basically how significant was the injury. And sometimes it will be concomitant injury in the cervical spine or another lower limb, or like something else intra-abdominal or around throat. These kind of things can happen. So
yeah. Thank you very much. So I'm just going to take a break from the questions and move to Dr. Volodymyr. It's great to have his expertise here. He has got lived experience in conflict zone. And if you could kindly share with us your experience on key points as to what worked really well and what could be improved?
Thank you very much, dear colleagues. A couple of specific details from the Ukrainian side. Over the past 10 plus years in Ukraine, we have had 3 processes happening at the same time with cross-influence. Medical reform started from 2017 and currently ongoing. The war with Russia started in 2014, since 2022 has expanded into full-scale invasion, as is also currently ongoing, and the development of the country's rehabilitation system started in 2016 and also currently ongoing. So care for war-related trauma cases in Ukraine is provided in regular healthcare facilities, predominantly municipal, where rehabilitation services are currently also developed. From the system delivery perspective, in response to war-related demands and acute war-related trauma, Ukraine integrated rehabilitation services, particularly non-specialized inpatient rehabilitation departments, into multi-profile municipal hospitals. So this approach made it possible to allocate rehabilitation professionals close to where acute medical care is provided, laying the foundations for acute rehabilitation services and optimizing acute subacute referrals. On the other hand, you may witness in both in Ukraine and in the ongoing Gulf War, a modern war is not only about frontline activities, as it was in the past, but also about warfare using different types of drones and other weapons targeting remote areas and countries initially assumed to be safe and unreachable. This is also changing the types of injuries. According to data from one of our neurosurgical colleagues, Dr. Sirko, chair of neurotrauma department at Mechnikov Hospital in Dnipro, the ratio of blast to bullet trauma, which was 87 to 13% during the period of 2014-2022, changed to 97 to 3% after beginning of full-scale invasion in 2022. The majority of such trauma is penetrating traumatic brain injury and is related to a drone attack. Many cases of war-related trauma in Ukraine are complex. You can imagine double amputations, multi-BI, colostoma, osteomyelitis, PTSD in one person. Another problem we are currently witnessing and trying to address is prepositioning of simple assistive products, including those for mobility and basic self-care for war trauma cases, provided by first-hand medical services in small stabilization points near the front line when transporting to acute medical wards at big multi-profile frontline hospitals and quickly referring from east to west for safer routes. This prepositioning shall be available across the whole stages of this pathway. Additional problem secondary to complication of referrals is huge levels of antimicrobial resistance, which is generally existed across Ukrainian war-related cases. So we are still building the pathways on subacute, outpatient, outside the hospital referrals and the system of rehabilitation delivered at community staff. One of problems is big internal displacement of persons inside the country and issues on home adaptation. In case it's a rented apartment, the matter of changing in a short time. So we are in the middle of high income settings, not the same as the classical conflict settings. So the system of healthcare is working, collaborating with the military healthcare system. So it's a lot of challenges, a lot of evolving questions, evolving processes. So this is, in short, what do we have in Ukraine? Over.
Thank you very much. I'll go back to the questions that are printed. So there's a question about who should be responsible for educating the family about post-functional deficits that may occur as patient is to be sent home? Is it the duty of the physio or the neurosurgeon? I would say it's the duty of the whole team, not just medical, but nursing, allied health, all of them. Anybody who is specialized in rehabilitation medicine should have the knowledge to educate and inform the team. There's another question about in a field hospital setting for a severe TBI with fluctuating GCS, no access to continuous neuromonitoring or advanced imaging. How do you decide the safe timing and intensity of early physiotherapy interventions, such as positioning, passive mobilization, sitting balance, without increasing the risk of secondary brain injury or intracranial pressure instability? So, Farooq, Anas, or Volodymyr, any of you want to take this?
I will start if everyone. So the question is about how to rehab or when to start rehabbing an individual with axonal brain injury. Is that correct?
No, it was the other question about, how safely can you start early physio interventions when you do not have the monitoring systems for raised ICP or scanning facility?
Okay, so you can start as early as possible. It's the same thing even wherever it is, as long as you are, as the patient is clinically stable. Now the patient in front of you, how there are signs of instability, you will see patients been having seizures, patient being confused, patient moving a lot or behavior disoriented. These are not, you can't do anything. If the patient is clinically stable and being calm, you can start, okay? Once the patient is clinically stable, okay, by looking at the patients, if you don't have the imaging, and you think that the patient is showing signs of disorientation, being behaviorally unstable, these kind of the signs that worrying, you need to be stepping back. You see, oh, maybe there's something pathology happening in the brain. But if you started and the patient is not following, that means that is not the appropriate time because you're starting causing problems. So always that in the first week or two that you'll find there is some challenges. But when you see the patient is calmly on the bed, the patient is not aggressive to anyone, not shouting, you can start coming into that position and you make sure that there is no causes of pain, there is no infections, which is like of a fever, or there is a wound causing problems. You can start that, but you treat things in a matter of acute, subacute, and chronic. So yeah, for me, it's to start early. Dr. Farooq, Dr. Golik?
Yes, yeah. I also wanted to add that another very common complication during the recovery phase of traumatic brain injury is development of hydrocephalus. So that can also cause increased pressure in the brain. And often looking for the triad of confusion, continence issue, and gait difficulties, gait ataxia, should alert you that there might be a complication happening and alert the doctors or physicians towards it. So that's another thing to be looking out for, besides everything Dr. Anas said. Anything else, Dr. Farooq or Dr. Volodymyr?
From Ukrainian perspective, all cases with TBI is not serving in the field hospital, but in the regular neurosurgical departments in multi-profile hospitals. So there is a matter of acute rehabilitation, even in case of non-stable situation of the person, maybe the positioning, the prophylaxis of contractures, this kind of stuff, but neurosurgeons is taking care of these patients from medical side. From rehabilitation side, according to our legislation, the responsible physician for rehabilitation is physical and rehabilitation medicine physician. So the collaboration of PRM physician and neurosurgeon is just a case to start any kind of early rehab. So we are trying to move this agenda forward, but anyway, it doesn't matter about the severity of condition. You can start slowly, and you can start with some passive activities to avoid the complication before the person is lying flat. That's it, over.
Now, the next question, how does diffuse axonal injury fundamentally alter the global efficiency of neural networks? And can motor learning protocols actually repair white matter connectivity? So I guess this is just boils down to neuroplasticity and what Dr. Anas has already explained in his slides. Repetition and practice over and over is what's going to help with the rewiring. And same for diffuse axonal injury as well. The principles are exactly the same. So the next question is, patients may have fluctuations in intracranial pressure. What are the specific safety parameters or red flags as a physiotherapist? We sort of answered this question to a degree, but Dr. Farouk, I see you nodding. Are there any particular red flags we should ask them to look out for?
Yeah, again, if you're working in a well-established center, you will have monitorings, will have monitors, people who are trained, and they would be able to pick up these early signs. But let's go back to a conflict zone where you even might not have continuous electricity. You do not have monitors. You don't have these kind of high-tech gadgets. So what do you do there? So I would recommend you go back to the basics. And I think it's a very important point to understand for all of the participants that we are living in a hyper-connected world where everything is sort of like taken over by this artificial intelligence, AI, and stuff like that. Despite all these things, we need to understand that as medical healthcare professionals and particularly rehabilitation professionals, we need to stick to our basics, which mean our clinical examinations and seeing the actual patient. So even if you do not have these high-tech monitoring gadgets available, what you can do is probably just monitor the Glasgow Coma scale of the patient. You see their blood pressure, whether their pulse is rising or not, whether they are starting having discomfort, what is their respiratory rate, what is their level of consciousness. So even without any high-tech gadgetry, which is obviously very good, and if it's available, we must use that, one can monitor a patient with TBI, whether he or she is deteriorating or responding to your physical therapy by simple clinical examination and by monitoring their clinical condition. So I would recommend that please always focus on your clinical skills, because there are going to be times when you will not have any access to high-tech gadgetry in a conflict or disaster zone, and then you have to rely on your own senses, your own clinical acumen, and your gut feeling that you have developed over the last couple of years by actually clinically examining the patients. Thank you.
Thank you. Now, from an anonymous attendee, we have the question,
Dr.
what about...
sorry, Volodymyr raised his hand, please. Sorry.
Yeah,
Okay,
just small information and experience from Ukraine in terms of no electricity, no any kind of potential supply. So how Ukraine prepares for this? All the hospitals do have multiple generators. So we are equipped, and we do have a huge experience of energy cuts. So, but again, it's from organizational, maybe not from clinical perspective, but we're equipped with the generators. In case of shelling, we do have the shelters, and multiple hospitals near the front line is currently developing the underground premises to run the several services, but underground. So not from health, but from organization perspective forward.
Mm-hmm. So the next question about what about cognitive dysfunction in traumatic brain injury? How can it be managed? And are we having any phase-wise protocol for that? So I can take this one. So in terms of cognitive rehabilitation, I can tell you what doesn't work. What doesn't work is getting patients to do puzzles or crosswords and things like that and hoping that will improve their cognition. What is really important is to set them up for everyday tasks and activities and set structure and routine. And when it comes to memory deficits, which are common after traumatic brain injury, teach them strategies for compensating for their memory deficits, such as putting reminders, writing things down, having a wall planner in their room and appointments stated on it. So it's strategies like that that's going to be more helpful than any sort of pen and paper exercise or mind games for cognitive training. The other commonly misunderstood symptom is cognitive fatigue. So brain is a high energy consuming organ, and an injured brain consumes even more due to all the inflammatory processes happening. So during that process, when the patient is recovering, any sort of cognitive overload, that is being in a noisy place, where there is light sensitivity, being constantly asked to do tasks and being challenged, could exhaust them. So they could develop a headache. The existing problems could get worse. So if they've got a weakness on one side, they can become more weak. Their speech could get worse. Their cognition could get worse. So it's really important to teach the patients and families to recognize symptoms of cognitive overload and help them to take rest breaks to prevent that from getting worse. So that's an important cognitive aspect. So understand cognitive fatigue, have strategies for memory, and then orient them to everyday routine and structure. That would be my response. Anything else anybody wants to add? Okay, then we've got a few questions more, so we will go to, okay, do the patients suffer from post-traumatic stress disorder? How do we deal with that? Who would like to take that question? Farooq?
I
Yeah.
first, yeah. So again, the first thing that we need to understand is the eye cannot see what the mind doesn't know. So if you do not even recognize that PTSD, that is post-traumatic stress disorder, can be a complication in case of TBI, probably you will not even look out for that. That's the first thing. And I totally agree, because in that disaster situation, the focus is usually on saving limb and life, which is fantastic. But we need to understand, when we talk of long-term integration, community integration, improved quality of life, and good functional outcome, PTSD is going to be a very important consideration. That's the first thing. Second thing is that I have often noticed that our main focus for some reason is usually on the patient themselves. But we are talking of patient with traumatic brain injury. It's not a simple fracture, it's not a simple headache. So we need to understand this, that this PTSD is not only going to occur in patient with TBI, it might actually occur in their caregivers as well. So in case of disaster situation, because both the patient and the caregivers are not only facing a medical situation, they're also facing a conflict and disaster situation, which itself is a major trigger for these kind of PTSDs. So you need to understand that this PTSD can occur in both of them. Then again, depending on your own local context, there are simple screening tools available. And this is where I feel that AI can help us a lot. So one of the things that we did, not with specifically with PTSD or TBI, but with another condition in rehabilitation, was that we fed a couple of good articles on a particular condition to this chat GPT. And we asked it to create a one-pager screening tool for us that we could rapidly deploy in those areas of my country, Pakistan, where we did not have early access to rehabilitation. And it actually created a pretty good kind of a single pager. And I think that all of us, because I can see that there are people for at least from 20 different countries, and all of us have different contexts. So you might want to do this experiment, that as an expert, you identify a couple of good articles on screening and assessment of PTSD in TBI. You feed those articles or those PDF to a good AI tool like maybe ChatGPT, maybe Gemini, or even Grok. And then you ask it to create a single page assessment tool that can be rapidly deployed in a resource constrained area or a conflict zone, and just see the results. I'm pretty sure it's going to help you a lot. Thank you.
Yes, Volodymyr.
Just one additional comment. Totally agree with Farooq and support the relevance of PTSD in delaying and avoiding the person to be involved in the active rehabilitation procedures. But additional comments from Ukrainian side. So, for instance, the persons who are returned back from the captivity. So if we do have the possibility to use some kind of as functional electrical stimulation, but in captivity, this person were the subject of torture with electrical shock. So this kind of stimulation is not available, is not applicable for such person because of lived experience of electrical shock. So another situation is when we are using some potential interventions with use of VR. So again, it may be the trigger factor for the persons wounded during the war who have been the drone operators. So because they are using traditionally this VR equipment for operating the drone. So again, all these components and all this specificity should be accounted, should be considered when our multidisciplinary rehabilitation team is putting the program in place and implementing the rehabilitation interventions. Thank you.
Thank you very much. So there's another question which is really important. Let me just read that out. Yeah. Mild and moderate TBI are often missed in conflicts, especially during mass casualty events or where there is multi-trauma. What advice can you give to rehab professionals who are seeing patients for other injuries who either notice symptoms of TBI or receive or report of such symptoms? So this is really important because traumatic brain injury can often be a hidden injury. A neurological deficit like weakness may not be evident. The patient might be walking, talking, looking good on the outside, but having a lot of deficits from a cognitive perspective. Brain injury is often a hidden injury. Patients can be walking, talking, and but they might have cognitive impairments, emotional, behavioral consequences. So when you're treating a patient perhaps with polytrauma, limb injuries, etc., and you're finding that either they are confused, disoriented, having memory deficits, or symptoms, headaches, things like that, vomiting, then you've got to have a high alert for possible traumatic brain injury as well and get them investigated with scans or whatever required to make a diagnosis of traumatic brain injury. So that's a very important point. Then this next question, in a conflict zone where access to CT or MRI is delayed or unavailable, what are the most reliable clinical indicators? Because there are many clinical indicators available. So most reliable. So we touched on that previously, but you want to talk about some of the clinical indicators again?
Yeah, I can touch base back. So the most one is that I would say you classify first mild, moderate, and severe, and that's because the most reliable, most reproducible, like you can repeat it every time, and it's easy tool to use. So if you want to know mild, moderate, severe, and then you classify it by knowing what is the GCS, Glasgow Coma Scale, and what is the time of post-traumatic amnesia, and how much time they've been having being unconscious. So these are the main thing for us. So you identify these three elements, identifying the time, and it was one of those slides. I can go back to this slide if I have time, but these are the main ones that, and the easiest tool. Now, one of the other things that you can look at is basically, as Professor Farouk mentioned, the clinical signs. If it's more about, before taking a patient to the CT or the MRI, basically you need to know what you are going to scan for. So that's why you need to examine the patients. A patient who had a trauma now, or we have a blast injury, is there something needed for the CT scan, or maybe there is a fracture in the limb that's more important now, is bleeding from. So you don't know sometimes. So you look at the conscious state, look at how much is there in GCS. If they are less than 9, there is like a rule that you look at. If they are less than 9, that would be more severe. If they can't maintain their airway, they can't grasping, they can't move, they can't follow the command, look at the GCS, because this is an easy one. Looking at the eye, the motor, the verbal, the best verbal, the best motor, the best eye movement. You look at these, and that will help you. Is that mild or moderate? Because if they are able, they will be conscious and they are moving and trying to escape from the situation. And if they are in a safe place, they will be more communicating. But if they are in a severe or mild or moderate, you will find the GCS will be a bit low. They can't communicate, they can't catch their air, they can't follow the command. I would say from that aspect, that's initial, but this is my thought about it. But what do you thought about it, Prof. Maria or Prof. Farouk?
Yeah, I agree completely. So Glasgow Coma Scale, pupillary size, signs and symptoms, confusion, disorientation, etc. Those are the clinical indicators, most reliable. Now, there is a comment in the chat which says occupational therapists should be a part of this webinar in the rehab of TBI. I agree.
Yeah.
We expect rehabilitation to be multidisciplinary, and so medical, nursing, allied health, including physio, OT, speech, should all, we would have loved to do a presentation which had input from everybody, but it was a bit of a short notice, and we were trying to pull it together as best as we could. But I suppose in future webinars, we'll definitely try to make it more multidisciplinary. Now, another question here. Hello, I'm a first-year student in the Department of Medical Rehab and Physical Therapy, and I would like to increase my knowledge of clinical cases. What books or resources would be helpful, especially regarding nervous system injuries, as they are common in Iraq?
Can I go first?
You go, Prof. Farouk. I think that's your field better.
Okay. So honestly, again, a personal note, this particular question of a first-year medical student reminds me of actually my own self. So my first exposure to this disaster rehabilitation was more than 20 years ago in October 2005, once we had one of the worst earthquakes in history of Pakistan. More than 70,000 people dead, including a whole generation of school-going kids. More than 126,000 people were injured. Many of them had permanent disabilities like traumatic brain injuries, spinal cord injuries, and long bone fractures. And honestly, I had the same question at that time. But you can very well imagine 20 years ago, working in Pakistan and LMIC with no DSL, no smartphone, stuff like that, how life was for me, and I was very frustrated. And honestly speaking, over the last 20 years, I have seen that this subspecialty of disaster medical rehabilitation has grown leaps and bounds. I have seen a couple of very good phenomena happening. The first is that now even surgeons and people who work in trauma and acute care, they have a realization that good care does not end with saving the life. It is the quality of life that matters over the next years. And this is what we do as rehabilitation professionals. That's the first thing. The second thing I have noticed is the major paradigm in which more and more rehabilitation professionals from different backgrounds, PM&R, physical therapy, occupational therapy, orthotists, prosthetists, SLP, they are collaborating and they are coordinating. And the third thing is the speed of this collaboration and this coordination is now very fast. Honestly, I actually sent out letters to my colleagues. I mean, I got their emails, I got their addresses. I actually sent them letters, which probably in that time took 2 to 3 weeks to reach there and then, get back the answer. But now just look at this webinar. It's a series of webinars that we are holding. It's a global collaboration of multiple international rehabilitation organizations, multiple people from multiple countries, speaker and expert on a single platform. So honestly, in a hyper-connected world, if you go online and if you search with focus, with intention, and you know what you're looking for, I'm pretty sure you're going to get the resources you're looking for. You are going to get the clinical cases. And the most important is you are going to learn and listen to the real actual world experience as my colleague, Professor Golik from Ukraine just told you. So I would say in a hyper-connected world, you can go online, but you have to do a focused search. You have to sort of like target your approach, what you are looking for. And I would invite everyone to please explore the website of International Society of Physical Medicine and Rehabilitation, and specifically the section on Emergency Rehabilitation Committee. I have shared the links and I'm going to share them again. You will find our previous presentation over the last 10 years done on different topics related to disaster rehabilitation, as well as context of our main key leaders. And I'm hopeful that this kind of collaboration is not only going to help you, it's going to help the patients that you serve. And since we all know that you never know when the next disaster will strike or when the next conflict will occur. So hopefully whatever you learn here, if you translate that into actual patient care at the bedside, hopefully you're going to save a life, improve the quality of life, and improve the community reintegration as well. Thank you.
Thank you, Farooq. Now I'll ask Volodymyr to share some parting wisdom before I draw the session to a close.
So again, coming back from our experience, we do have multiple comorbidity cases, polytrauma cases. So when we are trying to find some kind of general evidence about this, it's very difficult. So you cannot find the evidence, the multiple control trials about the cases with 4 and more health condition in one person. So what is happening in Ukraine in this situation, we are doing so-called problem-oriented learning. So if such kind of a patient is entering the rehabilitation department, we can compile our experience from the different perspectives, and the team is doing this kind of research based on the specific need of the specific patients which is in the ward. So the problem-oriented learning is totally available and totally applicable for such kind of conflict settings, because you potentially may not find the simple solutions. You are to be ready with to complex cases and to some innovative approach and some kind of improvisation in some cases. This is real life as of now, and thank you.
Thank you, Volodymyr. So I just would like to conclude this by again thanking WHO and World Physiotherapy. And 3 key takeaway messages that I'd like to reiterate. Number 1 is, for diagnosing and treating brain injury, you don't need sophisticated equipment or technology. You just need basic clinical skills. That's number 1. Number 2 is, we could involve family and start rehabilitation really early and, teach patients to do everyday functional activities. And number 3 is, brain injury can be a hidden disability, so do not miss it. So again, thank you all. Once again, thank you to Dr. Anas for the presentation and the panelists, Dr. Volodymyr and Dr. Farooq. It's almost 3 a.m. in the morning, and I have to start ward rounds at 9 a.m. Few hours. I'll try and get some sleep. Okay, thanks everyone. Bye.
Thanks everyone. Thank you. Bye-bye.
Thank you, Maria, and thank you everyone for attending. And thank you, Pete and Erica, for your support. We are grateful. Thank you. Take care. Bye.